Welcome. I'm Mark Kittleson, and I'm the chair of the Department of Public Health. And this is truly an international event. We have people throughout the world beaming in, so this is fantastic. This is the inaugural capstone for the Biostatistics program. I know they have been discussing putting this together for a couple years now, and so this is the first effort. So I think this has been an exciting year watching, or exciting semester watching them. For the students, congratulations. A lot of hard work, and this is what public health is about, where you work collaboratively with other individuals. And we appreciate, we have a wonderful international contingency of students. Saudi Arabia and many other countries, but Saudi Arabia certainly is well represented. And we really appreciate all your work. And you came into our program, and then the COVID hit, and so you have had to be very flexible. And so we appreciate that flexibility, and I wish you well in whatever your endeavors might be in the future. But I also think it's really critical that that we acknowledge your instructors. Dr. Kim and Dr. Shi have really gone over and beyond the call of duty when it comes to the work effort. And this work effort, besides the current semester, a lot of work, they've had several weeks before the semester started. So thank you, HaeYoung and Qiuhu, for your great support of your students. I see that Dean Ambler has arrived. He's been faithfully attending all of the presentations. So Dean Ambler, would you like to say a few words before I introduce the instructors?
Well, thank you very much. And I just want to express my appreciation to everybody who's worked so hard on this project, and of course your classmates working on the other projects as well. A big shout out to our great faculty in biostatistics, Dr. HaeYoung Kim, Dr. Qiuhu Shi. It's good to see you both. And really, Capstone Week has become Togetherness Week, because I've seen more of our faculty, we've seen more of each other and our students than the whole rest of the semester, only compared to Public Health Week. So it's great to get together. It's great to see the outcome of a very, very complicated project. And as I always say, I think that when you get this many people to try to work together on a coherently themed project, that is exactly what public health is all about. It's very unusual in public health for one expert to dwell on a problem and work out all the answers. That almost never happens. If there's ever a monument to diversity and inclusion and working collaboratively, it is public health, because most public health problems require input and ideas from lots of people with different backgrounds, different agendas, different likes and dislikes. And what comes out of that is a much better product than any one of us could come up with. And each of the capstones I've seen this week has given great proof of that. So thank you for being here tonight, and we look forward to getting started. Thanks.
Thank you, Dean Ambler. And before I introduce Dr. Kim and Dr. Shi, or before we get started, I do want to give a shout out to all the biostats faculty, obviously Dr. Kim and Dr. Shi, but also Dr. Nancy Stambler, and we've had a lot of other adjuncts who've taught. Probably COVID, between biostatistics and epi, they have had to make the most adjustments, and really difficult adjustments, teaching very complex courses. And so they've done a remarkable job. Congratulations. But I do want to acknowledge them. So with no further ado, Dr. HaeYoung Kim and Dr. Qiuhu Shi, thank you for doing this. And go ahead, Dr. Kim.
Okay, thank you, Dr. Kittleson and Dean Ambler. And then thank you everyone who joined today's Biostatistics capstone presentation. Our Biostatistics capstone group, they they have been working very hard for this project, starting from the literature review based on the research objective and applying their programming skill to create and manage a very large analysis data set, and also applying statistical methods they learned from the class to answer the research question using very complex and large data set, and also writing the abstract for the APHA. They are also currently preparing for the manuscript submission to the journal. And I also would like to thank you to Dr. Qiuhu, who was the co-instructor for this project and who gave us a very critical comment almost every week. Thank you again for joining us. And now I turn it over to our student.
Hello, everyone. Our team is going to present the Capstone project, and the title is Factors Associated with Cognitive Impairment Among Older Adults in US, Longitudinal Cohort Study, under the supervision of Dr. Kim and Dr. Shi. Next slide. I would like to introduce our team. مشاعل الغامدي,
إيناس الشهراني،
فاطمة الأحمدي،
نورة الغامدي،
فوز برناوي،
حسن الأحمدي،
حصة الطهيني،
نورة الشم.
When we start our project, it had touched us all because there were people we loved suffering from this problem in various ways. Personally, I lived this experience with my grandfather. I spent some of my childhood years with him. Now, he doesn't know who I am and doesn't know where he is. Some of my colleagues have the same experience with members of their families as well. This gave us the motivation to study cognitive impairment more and to understand the risk factors, as it not only affects the quality of someone's life, but also those of their loved ones. Aging is an important public health issue in the US and also throughout the world. Cognitive decline is considered one of the most feared aspects of aging. For this study, our main focus was the cognitive impairment among older adults. First, I start with the definition of cognitive impairment. It generally presents as a status of confusing, loss of memory, trouble understanding, or thinking or remembering that affect their daily life. There are two stages of cognitive impairment. The first stage is mild impairment, and that means people may begin to notice a change in cognitive function, but still be able to do their everyday activities. It is the stage between the expected cognitive decline of normal aging and the more serious decline of dementia. The second stage is severe impairment. It can lead to losing the ability to understanding the meaning or importance of something, and the ability to talk or write, which eventually they cannot live by themselves. According to CDC, there are more than 16 million people in the US have cognitive impairment, which is equal to twice the population of New York City. Next slide. This slide shows us some facts and figures to reveal the burden of cognitive impairment. Like, for example, during the COVID-19 pandemic, in the United States, rate of mortality of dementia and Alzheimer have increased to 16%. On other hand, more than 11 million Americans provide unpaid care for people with Alzheimer and other dementias. In addition, Between 2000 and 2019, death from heart disease have decreased to 70%, while death from Alzheimer's disease have increased to above 100%. Also, 1 in 3 seniors dies with Alzheimer's or other dementias. It's kill more than breast cancer and prostate cancer combined. Next slide. Cognitive impairments. It's considered as a public health issue in the rapidly aging country. It has the significant impact on individuals' overall health and well-being. The impact of cognitive impairment on people's life as they age is still complex and not understood. So, it's necessary to study and understand the risk factor for cognitive impairment in elderly people. Now, Noura take over with the objective of our projects.
Thanks, Michelle. Hi, everyone. Our objective, identifying the potential risk factors of cognitive impairment, is an effective way to prevent cognitive decline. Therefore, our study focused on identifying the factor associated with cognitive impairment and dementia. We used a publicly available data from a large-scale longitudinal cohort study based on the representative sample of US older adults. We found in most previous studies that have attempted to identify risk factor for cognitive decline. The continuous outcomes were used. For this study, we used the validate cutoff values to define the cognitive impairment or dementia, to identify the factors associated with the probability of developing cognitive impairment or dementia. A great number of risk factors for cognitive decline have been reported. For that, our study focused on the following 3 factors. First, socio-demographic factors. It includes age, which was our main predictor, gender, race, education, and income. Second, lifestyle factors. It includes smoking status, alcohol consumption, and physical activity. Last one, comorbid conditions. It includes obesity and depression. Now, Noura Al-Ghamdi will talk about the study information for our project.
Thank you, Noura, and thank you everyone for joining us. Today, I will talk about the study information. In this study, we used Health and Retirement Study data, which is a public resource for data on aging in America since 1990. And it is a powerful research tool for tracking and understanding important social changes and potential policy responses. Health and Retirement Study data is a longitudinal panel study, and this is intended to collect a repeated measure for the same subject at different points in time, and then comparing each individual's measures at different times point. What distinguishes the HRS sample is that represent the entire US population age 50 and older. This makes the study generalizable to all regions of the country. For our study, the participants are re-examined every 2 years in terms of their health and social and economic information. HRS data supported by the National Institute on Aging. Their focus is to understand the nature of aging and enhanced health for healthy and active years of life. And it is funding from the Social Security Administration. Next, please. This graph depicts the HRS longitudinal cohort sample design. The blue color represents the initial 1992 HRS cohort, and other colors indicate other cohorts added after the initial HRS study. For this capstone project, we used the initial HRS cohort. On the left side of the graph, we can see the entry year for the participant and following them up over these years with increasing age. The initial 1992 HRS cohort consisted of persons born 1931 to 1941, who were then aged 51 to 61. Members of this HRS cohort, now in their 17th and 18th, have been interviewed every 2 years since 1992. Next, please. For the study, the eligibility criteria were those participants who are aged 50 or older, and those who entered the study at or after 2004, and who participated the study between 2004 and 2016. Those with 3 or more follow-up data were included in our project. Now Foz will introduce the study outcome.
Thank you, Nora. The outcome of this study shows that cognitive function was based on a 27-point measure, also based on the test on cognitive test performed in 2004 to 2016 of the health retirement study. And the test has been validated for use and was a composite measure of cognition based on 3 aspects of cognitive function: episodic memory, working memory, and processing speed. The first cognitive function was episodic memory. Memory was assessed using two word list recall task, 10 item for immediate recall test and 10 item for delayed recall test. For the immediate recall test, the interviewer read a list of 20 words to the respondents and ask the respondent to recall as many words as possible from the list in any order. Whereas for the delayed recall test, after approximately 5 minutes of asking other questions to the participant, the respondent was asked to recall the word previously presented as a part of the immediate recall task. For all of that, the number of words were recalled correctly were counted. And the total range was from 0 to 20. Moreover, the participant who tried but unable to recall any word, they received a score of 0. And the second cognitive function was working memory. Respondents were asked to subtract by 7 a total 5 times, starting from 100, and continue subtracting 7 from each subsequent number for a total of 5 trials. So it was counted how many subtractions they had. And the test name for the working memory was 07 test, and the range from 0 to 5 points. For example, about this test, if the participant who correctly subtraction for all 5 times, they receive a score of 5. But if the participant did wrong subtraction for all 5 times, they receive a 0 of score. And the last cognitive function was processing speed. It includes a backward count exercise, which asks the respondent to count backward for 10 continuous numbers beginning with the number 20. However, the respondents were allowed to trail for each exercise. All of that, every backward count was assigned to 3 categories variables. If the participant did incorrectly in both tries, they received a 0 score. But if the participant did a correct on the first try, they received a 2 score. Because of that, the range here for the processing speed from 0 to 2 points. So we can clearly see that cognitive functioning was the total of cognitive score was calculated as the summation of episodic memory, working memory, and processing speed for each participant, with the range from 0 to 27. Following this study, a higher cognition scores indicate better cognitive abilities. Next slide, please. For this study, we used cut points of cognitive function, which were based on prior studies with the health retirement study data. These cut points have been validated for differentiating normal cognitive functioning from impaired function. So, those scores of less than 7 on the 27-point cognitive measure indicate the presence of dementia. And for those with the score between 7 and 11, they are classified as a cognitive impairment, but without or no dementia. In addition, for those with the score greater than 12 or equal 12 points, they are classified as anormal. According to the study, we define 2 outcomes using these cut points. One binary outcome was defines cognitive impairment versus normal, and another binary outcome was defined as a dementia with no dementia. Next slide, please. Our study objective was to identify the risk factor for cognitive impairment among older adults in the United States. For this study, we focused on the following 3 factors. I will explain about the socio-demographic factors. So, the socio-demographic factors include the following variables. The first and the main predictor for this study was age. In the present study, as repeated measure cognitive outcome variable were used. However, cognitive impairment is the disease related to the age, and to understand better on the development of cognitive impairment over time, we used the time varying age variable. We also aim in this study to see how the probability of cognitive impairment changes over the age for each group of covariates. The second and third variable were gender and race. For the race, we used 4 categories: non-Hispanic white, non-Hispanic black, Hispanic, and others. And the fourth variable was years of education. This variable was classified into 4 categories based on the number of years of education. From 0 to 8, years indicate the lower education. From more than 12 years indicate the higher education. Last but not least variable was household annual income. For this study, the tier-type cut-off values were used to make almost equal size 3 groups. And the last variable was marital status. We used 4 categories variable which classified the participant depend on these status as never married, widowed, separated, or divorced, and married. Now my partner Mahasen, she will continue explain the rest of covariates and predictors.
Thank you, Foz. We also used the lifestyle factors at baseline visit, and it includes smoking, alcohol consumption, and vigorous physical activity. Tobacco smoking status was categorized into 3 groups: never smoker, former smoker, and current smoker, based on self-reported responses to 2 questions. Have you ever smoked cigarette? And do you smoke cigarettes now? Alcohol consumption was assessed using the questions related to ever drunk non-alcoholic beverages, the number of days of drinking per week, and the number of drinks per day. On the basis of the answers to those questions, we categorized the participants as never drinkers, former drinkers, or current drinkers. Former drinkers were defined as participants who drank alcohol more than 3 months before the baseline interview. And current drinkers were defined as participants who drank alcohol within 3 months before the interview. For current drinkers, we calculated the alcohol consumption as the product of the number of days of drinking per week and the number of drinks per day. Current drinkers were then further categorized as low to moderate or heavy drinkers. Women with 8 or more drinks per week, or men with 15 or more drinks per week, were categorized as heavy drinkers. Otherwise, current drinkers were defined as low to moderate drinkers. For vigorous physical activity, we categorize it as 1 or more activity per week versus no physical activity. Vigorous activities include running or jogging, swimming, cycling, or game workout, tennis, or digging with a spade or shovel. Next slide, please. The last factor was comorbid conditions. At baseline visit, it includes obesity, number of chronic disease, and depression. For obesity, it was defined as body mass index greater or equal 30. It was categorized into 2 groups, obesity versus no obesity. For the number of chronic diseases, the count of 8 self-reported conditions was used. For those who were taking the medication,
the last factors was comorbid conditions. At baseline visit, it includes obesity, number of chronic disease, and depression. For obesity, it was defined as BMI larger than 30. It was categorized in 2 groups, obesity versus no obesity. For the number of chronic disease, the count of 8 self-reported conditions was used. for those who were taking the medication for the specific condition, they were also included for the count. The range was from 0 to 8. 0 indicate that the participant had no chronic condition. We used the 3 categories based on this: 1, 2, 3, or more chronic disease. For the depression, an 8-item version on the Center of Epidemiologic Studies depression scale was used. It asking whether persons have the following symptom in the week: depression, lack of happiness, or loneliness, or sadness. That everything was an effort. Sleep was restless, inability to get going, to lack of energy. The total number of yes represents was summed to calculate an overall depression score with a range of 0 to 8. Participants with score less than 3, larger than 3, was considered have high depression symptoms. Next slide.
Okay.
Next slide, we will discuss about the statistical analysis method. First one, data analysis were performed using data from participants with complete observation. The longitudinal study with the repeated measure data was used for this study. For this study, observation from an individual tend to be correlated, and the correlation must be taken into account for the validity inference. Failure to take into account correlation would lead to the regression estimates being less efficient, meaning they would be more widely scattered around the true population value. Generalized estimate equation, GEE, method was used to take into account the correlation within subject data within binary outcome. The SAS procedure, gen mode with repeated statement, was used. The univariate GEE model was fit for each covariant separately. For those variables which were significant at the univariate models, the multivariate model, the multivariate GEE models was fit with multi-independent variables in the same models. The significant level as 0.05 was used. Also, we conduct the sensitivity analysis using the missing income to assess the representativeness of the finding based on the primary analysis. Next, Inas will be explained about the study results.
Okay, thank you so much, Mashail. Hi, everyone. My name is Inas Shahrani. I will explain participant characteristics and predictor of cognitive impairment for our study. So let's start with participant characteristics. Overall, the sample consisted of 7,108 participants who we followed up of an average of 7.4 years between 2004-2016. And they contributed 29,207 observations. The participants had an average age of 54.7 years that ranged from 50 to 93 years at baseline. And the sample consisted of 52.9% were women. Approximately half of participants were non-Hispanic white, followed by non-Hispanic Black and Hispanic. 58.2% were married, and 55.4% had more than 12 years of education. According to baseline data, 24% were the current smoker, 45% were current drinkers. The average cognition score at baseline was 15.67 on a scale with range 0 to 27, where lower score showed impairment. And the average baseline BMI was 29.4. At baseline, 13.5% had the CIND, which is cognitive impairment, no dementia, and 2.1% had the dementia. These were measured using the cognitive function scale. So people with dementia had score of 0 to 6 points, and those with cognitive impairment, no dementia, had 7 to 11 points. As you know, lower score means bad score. However, high score means it's a good score. Most covariates had less than 1% missing data, except income that had 17% missing data. Next slide, please. Okay, results in table on this slide shows odds ratio for the predictors of cognitive impairment. Also, you can clearly see an adjusted odd ratio and a odd ratio. Unadjusted OR is the unadjusted OR from the unadjusted generalized estimating equations model, and AOR is for the adjusted OR from adjusted GE model. So for unadjusted, we are looking at one variable at a time. For example, age. What's the associated between age and cognitive impairment? So age is alone. However, in adjusted, we have all the variables in one model. And then we see what's the odd ratio. Before I explain all the variables that we have in this study, I want to mention about the 95% confidence intervals. As you know, if the confidence intervals contain 1, that means it's not significantly associated. If it's not, that means significantly associated. Overall, every 5 years increase in age, there was 24% to 28% increased chance to develop cognitive impairment. For the second covariate, we can observe in the unadjusted model, gender was not significantly associated. The average lifespan is about 5 years longer for women than men in the United States, without adjusted for age. It may be hard to conclude the effect of gender. So we use the gender variable in the adjusted model. In the adjusted model, men were significantly more likely to have cognitive impairment compared to women. For race data, we have seen non-Hispanic Black and Hispanic were about 4 times, and other race were 2.6 times more likely to develop cognitive impairment because odd ratio was greater than 1 compared to non-Hispanic white. We can see also married people has benefit, married at home, and they have more talk with each other, more stable. So compared to others, never married, widowed, and separated, divorced, they all have the odd ratio larger than 1. For education, we are not surprised. We noticed the participants who have more than 12 years of education were significantly associated with better cognition compared to those with lower education that have an elevated odds of getting cognitive impairment. Then go to the income. You see that clearly those in lower income and average income had a higher probability of developing cognitive impairment compared to higher income. Relative to those who never smoked, current smokers were associated with higher odds for cognitive impairment since the odds ratio more than 1. Interestingly, we found low to moderate alcohol reduced developing cognitive impairments. Heavy drinkers were significant in the univariate, but it was not in the multivariate model. So we may need to do more research, and also we need to looking for different cut points, how to predict cognitive failure for future. For figures physical activity, they were significantly associated with better cognition compared to no. After we adjusted the other covariates, figures activity is no longer statistically significant with cognitive impairment. For public health problems, we can see obesity was significant predictor in the univariate, but it makes our model unstable when we include it in the multivariate model, since it was also highly associated with other covariates. So we did not use it for the adjusted model. And also we checked the exciting research. We found some studies say obesity was more likely to get cognitive impairment. Others said it may not significant. So more research is needed to be done for this. For CESD, which is Center for Epidemiological Studies Depression, those with depression were more likely to get cognitive impairment compared to those with no depression. Finally, people with 2 or more chronic disease are twice as likely to get cognitive impairment, while those with only 1 are 1.15 times as likely to get cognitive compared to those with no chronic disease. Moreover, we can see 1 chronic disease in the unadjusted was significant. However, after adjusted, it became not significant because the confidence intervals contain 1. Next slide will be presented with Fatima.
Thank you, Ines. Now I will discuss about the dementia outcome used in this study. To identify the risk factor of dementia, we have conducted an adjusted model and adjusted model. The results we found were similar as the result from the cognitive impairment. If we take a look for the age variables from our result and adjusted model, 1.41, it means that there was about 41% increase in chance to have dementia for every 5 years old, increasing in age. Also, the 95 confidence interval does not include 1, which is mean age is significantly associated with dementia. For the gender was not significantly associated in adjusted model because in our study, there more of the half of the participants were females. To take into account, the average lifespan different for gender. So we decide to include it in the final model. What we found after the adjusting for age and other covariate, gender became significantly associated with dementia. For the education, from unadjusted and adjusted models, having a higher level of education make the participant less likely to have dementia. It may reflect that those with higher income, with higher education, maybe they spend more time to maintain better health choices to reduce the chance of developing dementia. Income is one of the important factors as it impacts life. A higher annual income may be helpful to resolve that issues that elder people faced. In our study, the results showed that having a higher annual income make the participant less likely to have dementia. In this study, we have a higher percent of the missing data, so we include the missing category for the main result. And also, we conduct the sensitivity analysis by excluding those people with missing income to clarify whether the missing income data will affect the result or not. We found that the result from the sensitivity analysis were similar as the main result. For the obesity, as in the previous models, for the cognitive impairment, we didn't use the obesity in adjusted model, since it was highly correlated with other variables. With increasing age, the symptoms of depression may increase in the participant. We observed from both models that those with depression more likely to have dementia. Finally, for smoking status and alcohol consumption, physical activity were no longer significantly associated with dementia after adjusting for other factors. Next slide, please. Since the cognitive impairment is the age-related disease, it is important to understand the pattern of a probability of developing cognitive impairment by each covariate over the age. We use SAS software to create figures to illustrate the predicted probabilities of cognitive impairment over the age. As you can see from the graphs, the y-axis shows the predicted probability of cognitive impairment, and the x-axis shows the age from 50 to 85. Each colored line refers to a specific category, as it's showing in the small box in our left side for each figures. So we can say that the probability of developing cognitive impairment are increasing as the age increase for all of these cases. Let's start with the first figures, which is for the predicted probabilities of cognitive impairment by race. For the non-Hispanic Black, which is the red line, had a highest probability of developing cognitive impairment over increasing age. The predicted probability to have cognitive impairment increased for the non-Hispanic White, which is the blue line, from 5% at age of 55 to 32% at age of 85. On the other hand, for the non-Hispanic Black, it increased from 25% at the age of 55 to 53% at age of 85. After the age of 70, there was a rapid increase in the probability of developing cognitive impairment for the non-Hispanic White race. And one possible reason for that in our study, there were more white race who was older adults. Also, when we check, we found that enormous studies, they found that African American have performed worse on average than whites on tests of cognitive function. For the second and third figures, they are for the predicted probability of cognitive impairment for each of education and income. We can clearly see that those with better education, which is brown line, and higher income with a green line, continue to have a lower probability of developing cognitive impairment as the age increase. If we take a look at the second figures, which is for education, at the age of 70, participants with the blue line indicate the worst education level, the lowest education level. They had about 5 times higher probability of developing cognitive impairment than the participant with highest level of education with the brown line. For the last figures, which is the income figure, the green line shows that the predicted probability for those with higher income also remain to be low over increasing age. This may be also related to the race disparity in education and income. Next slide, please. To the first figures on our side, there are 4 the predicted probabilities of cognitive impairment for each of smoking status and alcohol consumption. For smoking status, after the age of 65, there was a rapid increase in the probability of developing cognitive impairment for the former smokers, which is the blue line. This may be because in our study, there was more older adult people who was the former smokers. The probability of developing cognitive impairment for the never smokers with a green line remained to be low over the increasing age. From the figures of alcohol consumption, interestingly, we found that the low to moderate drinkers with the green line had a lowest probability of developing cognitive impairment at early age and consistently remained to be low as increasing age. The probability for the former drinker with red line increased rapidly after the age of 70, and they may be confounding effect for the age. If we take a look for the 2 figures in the lower side, they are for the predicted probability of cognitive impairment for the number of chronic disease and depression. We notice that with increasing age, those with more chronic disease, which is the green line, and those with depression with red line, lead to an increasing in the probability of developing cognitive impairment. On another hand, for those with 2 or more chronic disease, the probability was 20% at age of 55, but it increased almost about 50% at age of 85. For those with 1 or no chronic disease, with red and blue lines, the chance of developing cognitive impairment remained to be low over increasing age. From the last figures, for those with depression, the probability was also increased from 20% at age 50 to about 50% at age of 85. Finally, participants with no depression, they get benefit. With blue line, they get benefit. So they have a lower predicted probability of developing cognitive impairment over increasing age. My partner Nora will explain about the discussion for this study in the next slide.
Thank you, Fatma. In summary, we use the longitudinal data to study the factors associated with cognitive impairment among older adults in the US. Many previous studies used the cross-sectional data, and some studies used the longitudinal data. In those studies that used the longitudinal data, the continuous outcomes were used, and the linear mixed models were used to assess the association between the longitudinal changes in cognitive or to examine the trajectory differences among individuals. For this study, we used validated cutoff values to define the cognitive impairment or dementia. Cut points for cognitive function were based on prior study with the HRS data. The uniqueness for our study is that the results are illustrated in the pattern of the predicted probability of cognitive impairment by each group of covariates with increasing age. Our study also contributed to understand the mechanism of risk factors on developing cognitive impairment or dementia. Next, please. Our study illustrated the importance of examining risk factor for cognitive impairment or dementia much earlier in the life course. African Americans and Hispanic performed worse in cognitive performance as age increases. Similar to other studies, we found the beneficial effect of better education and higher income. Race disparities in education attainment and income may contribute to cognitive performance disparities as age increases. Better education and higher income may reflect better health or other behavioral choices that, in turn, lead to maintenance of cognitive function. Our study contributed further evidence that among a nationally representative sample of older adults, low to moderate drinking was associated with the lower probability of developing cognitive impairment that may increase with age. Several studies have found that low to moderate alcohol consumption is associated with the better cardiovascular functions, fewer cardiac events, and longer survival compared with abstainers and heavy drinkers. Thus, the decreased odds of cognitive impairment has been thought to be associated with the low to moderate alcohol consumption. Many studies have demonstrated that in the elderly population, overweight and obesity were related to self-report functional limitation, urinary incontinence, and chronic osteoarthritis pain. But controversies still exist regarding the relationship between BMI and cognitive ability in older people. A positive relationship between BMI and cognition has been demonstrated, although some other reports have showed an inverse association between obesity and cognitive performance. Because of that, further research should be done to understand the effect of obesity in cognitive impairment. For last, preventive strategies for cognitive impairment may need to begin early. improving one's unhealthy lifestyle and managing comorbid condition could help prevent or slow down cognitive decline. Now Hissa will continue with the strength and the limitation for our study.
Thank you so much, Noura. As Noura said, I will take the strength and the limitation for this study, and I'm gonna start ahead with the strength. Our study has several strengths. First, we use data from nationally representative large sample size of middle-aged or older US adults. And when we're saying we use large sample size, we proudly can say the result can be generalized to all the middle-aged or older US adults. Second, repeated measure. As we know, cognitive impairment is associated with the age. So we assuming there is several changes or developmenting is going to happen to the participants over the time. Based on that, we used longitudinal method. This method is more powerful than cross-sectional studies. Basically, longitudinal method is measuring the participant for several times, and instead measuring the participant for one time, and this is how the cross-sectional studies work. Using this method allow us to detect that developmenting and the changes may increase by the age. Also, using this method can provide high accuracy when the observing a change. Third, we use generalized estimating equitation method, which is called GEE model. We use this method to investigate the factors associated with the outcome. This method can be easily incorporated into the measure statistical software, such as SAS program, and also the model is robust to the misspecification of correlation structure. When the working correlation structure is correctly specified, the parameter estimates from GEE model are efficient. Next slide, please. Now we will look to the limitation. There are several potential limitations for this study. First, self-reported questionnaires. Some study variables were self-reported, and it may introduce recall bias. For example, we have the alcohol consumption was self-reported, and it may classify the heavy drinkers as low to moderate drinkers. And this is because the participants tend to underestimate their alcohol consumption. Second, our primary cognitive performance scale was a global cognition measure that primarily measure memory and processing speed. But individual cognitive domains were not used. More comprehensive assessment would provide more sensitive assessment of cognitive function. Hearing loss could also limit cognitive assessment in person or by the phone. If it sounds complex, I will break it down for you by giving an example. Now we have the participant. We will divide the participant for two groups. First one, they don't have an issue with hearing. They can hear well. The second group, they have this issue. I'm making a survey. I'm asking a questions. Logically, the first group, they can hear well the questions and they will answer. Maybe not correctly, but immediately. People with hearing loss, they will answer wrong to the questions. And this is an issue is going to impact the quality of the survey. So future research needed for this issue. Third, more than 15% of participants had missing data for the baseline income. It may be possible the participant with lower income maybe not record or reported their income. This study included those participants who had at least 3 outcomes measurements. Some participants had missing visits between the baseline until the last visit. For future research, imputation method may need to be done as sensitivity analysis to handle this issue. 4, and last one, age was time-dependent variable, but we used other covariates, such as alcohol consumption, smoking, etc. It were measured at the baseline visit. Cognitive function tends to change with the time. Thus, this change may be associated with the other factors that led to change in cognitive function. Future studies is needed to count this possibility. Next slide, please. Here is the list of the references used to this study. And I'm happy to say we are currently preparing for manuscript submission to the journal. Next, please. Biostatistics group would like to thank Dr. Kim and Dr. Shi for their guidance and their advice, and we couldn't do this without you. And I would love to remind all the audience, data used in this study come from the Health and Retirement Study, which is funded by the grant from National Institute on Aging and Supplemental, supported from the Social Security Administration and is contributed by the University of Michigan. Finally, thank you for everyone, starting from the head of the department to all the professors, to all of you guys for your patience and your time. Now it's time for the questions, and we'll be happy to answer all the questions they might have. Thank you so much.
Outstanding. This was a great presentation. You are all officially smart people. This is great. Congratulations.
Thank you, Dr. Qiuhu.